a part of Everlife, which has leading lab and analytical equipments platform in South and Southeast Asia, whereas Translumina is taking care of cardiovascular solutions provider in emerging Asian Europe market. And if we talk about our diversified portfolio, so we do have cardiovascular, in vitro diagnostics and scientific lab solutions, wherein we play a number one as position in scientific lab solutions in Southeast Asia, number two in stents in India, and we have taken a share of 18% in coronary stents in Indian market. So unparalleled market access, which has we have 2,000 plus hospitals and cath labs directly covered from our portfolio, and 17,000 plus laboratory directly covered, wherein 350 distributors we have in 60 plus of countries. So our strong R&D and manufacturing facilities lies wherein 100 plus SKUs are manufactured, and 7 manufacturing centers are there in Europe and India, and 2 R&D centers. So deep dive Translumina, the interventional cardiology business of Integris MedTech, wherein our just like I have mentioned, our global sales presence is there in with distributors network in 50 plus countries, and our across India, Germany, and Netherlands, we have our diversified manufacturing units. And taking you through our strong partnership track record, Shockwave, Asahi Intake, Assist, Hemonetics, and Sys Medical, wherein our product journey expertise basically lies with ability to take novel technologies from clinic to market and taking you through strong clinical and regulatory marketing expertise. Establishing manufacturing facility with a focus on structural heart products, with a facility being set up in Vizag, potential for manufacturing other products as well. This is our comprehensive product portfolio, wherein access, assess, and then treat, enabled lesion preparation and then treat, wherein we have our products with Yukon Choice, Vivo Isar, Protege, and recently we have launched with Medinol. So this is a picture wherein when Translumina has acquired Blue Medical Devices, wherein an acquisition has taken place and given access to a patented, innovative, and proven next generation drug-coated balloon technology. And that is Protege. Protege is Patel Excel coated coronary balloon dilatation catheter, which has its global presence in more than 35 countries. And our R&D and manufacturing unit lies in Netherlands. And Protege is EU MDR certified with patented technology access. So why we are unique? Because of its unique drug coding application process, which saves minimal drug loss during the transition. Wing seal technology, which has corrugation over the surface of the balloon and ensures effective drug delivery at the lesion site. And just because of the drug, which is secured so safely within the trifolds of the balloon, multiple drug release up to 3 times with the same device in the same vessel is possible. So Translumina is the only company which has its world's first only non-compliant drug-coated balloon. So now I would like to thank you all to take you have taken your time, precious time out for the DEBTalks and sharing the insights with our internal faculty members and as well as the attendees which are actually watching us for this session. So I would really like to thank Dr. E. Babu to accept as a position for chairperson and for the speaker and sharing his insights. And thank you, Dr. Sriram sir, for joining our session and to be the course director. Dr. Sriram is basically consultant interventional cardiologist from Dr. Mehta's Hospital, Tamil Nadu. We have Dr. Narendran Pandukaran, consultant interventional cardiologist from Dr. Mehta's Hospital, Tamil Nadu, and sir is also one of the course directors and would be taking us through the whole session. So thank you to both of you, and I would just like to take just hand over the session to you, sir.
Thank you, Garima. It's really nice of Translumina to give me an opportunity to head this webinar. I invite all the faculties. Dr. Ilayaraja sir needs no introduction, and as well as Dr. Babu Yerumali sir also needs no introduction. So without wastage of time, I'll just move on to the topic. I will invite Ilayaraja sir to deliver his talk, PCT updates, and case-based discussions. Ilayaraja sir, it's yours.
Sir, thanks for the warm introduction and thanks for the opportunity. Is the slide visible there?
Yes, sir. Yes, sir. It's visible. Yeah.
So some of the few interesting update on DCB and what happened in the recent TCT, I would like to share a few minutes, and then I would like to show you some one or two cases from my side. So we moved on from plain old balloon angioplasty to BMS, DES, and then right now we are using this DCB strategy, leaving nothing behind. And if you look at this DCB, basically it is a conventional semi-compliant balloon covered with the anti-proliferative drug. And then it is released during that plain POBA technique method. And when the contact is very less, for example, 1 full minute, but then basically it's a lipophilic drug, and then tissue penetration is good. So it stays there for a longer period, maybe up to 2 weeks, and then it does its physiologically effect. So key advantages of DCB are no metal strategy, and then homogeneous drug delivery across the lesion, and then complex anatomy. When they say complex anatomy, basically we look at these aspects, say long lesions, calcific lesions, and then bifurcation lesions. Of course, say instant restenosis, and then small caliber vessels. So wherever there is a relatively difficulty in dealing these lesions with a metal strategy, then there we can use a DCB with a comparable outcome or better outcome. So that is the concept as of now. One or two words about paclitaxel, because in the DES era, Limas DES, they favored better clinical profile when compared to taxes. So usage of taxes stents fell out of favor. But what is happening as of now with the advancement of the DCB role in this PCI era, modern PCI era, paclitaxel find a role. So basically, when compared to Limas drug, taxes group, they are lipophilic, so higher tissue penetration, and stays there for a period of minimum 10 to 14 days, and provides adequate, that anti-proliferative effect without causing much, say, damage in the form of apoptosis, and then it favors a quicker vessel healing and a fast endothelialization. Obviously, that is going to reduce the DAPT therapy. So this is the idea. When compared to DES, DCB acts at the level of a G1 phase, and then it starts working exactly after 4 hours, and then the whole effect is lasting for 2 weeks. Now, with reference to Limas, taxus group, they show more of lipophilic and then prolonged tissue tension. That is how in the DES era, paclitaxel somehow fell out of favor, but whereas in the DCB era, again, paclitaxel plays a key role. If you look at Limas, this is a hydrophilic, and then lesser tissue retention. So that is the only difference there. But then both drugs works when they are used as standalone strategy. In de novo lesions, by using DCB, especially long lesions, calcific lesions, and then say bifurcation lesions, and then small caliber vessels. If you look at the clinical subset, namely diabetes mellitus and then CKD, where we expect high calcific lesions and then high bleeding risk group. So this is a clinical strategy, and then that's an anatomical subset. In those situations, when DCB is used, it is a really attractive strategy, because it is going to avoid the drug-eluting stents in a HBR group, and then cut short the DAPT group, and then wherever we expect a kind of the inadequate outcome with drug-eluting stents or metal strategy for those complex anatomy, this is on par with the results without metal there. If you look at the evolution of DCB, we have a lot of trials from 2010 to 2019 involving so many authors. Now in this session, we would like to show you what is updated in the TCT 2025. So let us start with this solution de novo trial presented by Spalding et al. Group. And then this is basically European multi-center study, 12 countries, and then a minimum of 62 sites with a good number, say more than 3,000 patients. Basically, they divided the group into two. One is standalone sirolimus DCB versus a systematic DES technique. But after DCB, the randomization done, or sorry, after lesion preparation, the randomization done. That is the one limitation here because it's an open label trial. And then after randomization, if they feel that bailout stenting is needed, then that is offered. So even then, when the results are good, they stayed only with the balloon. So basically, good number of patients, say 1,600 with the DB alone, and then versus the rest of the patients. So they compared these two set of groups. Obviously, STEMI situations, CTO, and then left brain lesions, graft lesions are excluded. And they all followed the patients for a period of 1 year and then 5 years results. So in terms of target vessel failure and then recurrent MI or a redo procedure, and then of course mortality. This is how the primary as well as secondary points over a period of 1 year and 5 years. They looked at that. What we have to realize, the vessel size is somewhere between 2 to 4 millimeter, and then they all represented various subsets. And then they included all clinical subset, DM, CKD, and HBR group, versus a lesion subsets also long lesion, calcific lesions, and bifurcation lesions are all addressed. So the clinical subset excluded are STEMI situations, obviously left brain lesions, and then CABG graft lesions. So they followed the patients for more than 1 year. And in this strategy, it is found that the DCB alone, standalone technique, and the results non-inferior to the systematic DES group. Basically, it's an open label trial. One should remember this finding because you do DCB, and then when there is elastic recoiling, when you are not happy with the results, they looked at all the trials. They looked at the three key aspects. How do you define a DCB success after a DCB, and then look at there is no angiographically dissection, say flow limiting dissection or dissection more than grade B, it is not there, and then residual stress is less than 30%. If FFR is used, maybe the job is done. So FFR more than 0.8. So they looked at the three aspects. At least when we do angiography method, see that there is no flow limiting dissection. That is very important. Of course, there is no correlation between angiographic flow dissection grade based upon NHBLI versus imaging technique based dissection. Why I wanted to convey this, because we would like to take others' understanding and opinion on that. But in general, if you look at angiographically, if there is no flow limiting dissection, and then they left it as such. Let us move on to the next trial. In this, again, this is from Italy by Ginger et al. Here, they looked at in a different perspective. This is a single arm registry, meaning they have chosen certain lesion subset, say long lesion more than 2.5 centimeter with the reference vessel diameter of more than 2 mm. And then they just followed 110 patients. And they did DCB, and so wherever the indicated the same the clinical subset I mentioned for the previous study, and then they looked at the lumen loss and luminal gain. So exactly angiography follow-up, and then clinical measures follow after 9 months. So they followed the patients for a period of 9 months, and then they did a QC outcome, and a clinical outcome. So basically, in this, what we should look at is that, so how many of them required bailout stenting? Because they used only single arm, they directly chosen DCB, and these 110 patients, look at this, they required at least 4 or 5 patients required bailout stenting. Device success in balloon, it's not a big deal. So they noticed a dissection type A and B. Again, a single digit number with this magic touch balloon. Maybe, so when there is no flow limiting dissection, they left it as such. And then again, the conclusion is, if you look at the clinical outcomes, the luminal gain or loss, it is really comparable with the other reports reported from other registries, because it's basically a single arm registry, and they equated from the results with the other trials. And this is about paclitaxel. This is again from Nakamura. Basically, this is Japanese study, but Japanese study, multi-center study, say 1,800 patients, very good number of patients. Here they used paclitaxel and then imaging guided PCI. So here again, good number of patients. say 1,500, more than 1,500 patients, standalone DCB. Where they felt that is not sufficient, they moved on to a hybrid strategy and then put them on stenting. So that is around some 10% in number, that is around 200 patients. So finally, they looked at the clinical outcome as well as the TLF redo procedures, MI, and then mortality. So primary endpoints, secondary endpoints, and then over a period of 1 year follow-up. And final conclusion is that this is really feasible, and then the results are really effective, especially in the lesion complexity. And that is really a good number and comparable results. What is observed with other trials, they are in line with those results. Now coming to our Translumina Protege DB, it is really safe and effective in de novo lesions. When compared to the previous trials, here in Netherlands, they took say 4 centers here, and then about some 500 patients, de novo lesions 100, some 382 patients, ISR patients. So basically, in those patients, they used a Protege drug-eluting balloon in real-world all-comer trial. So again, they looked at 12 months follow-up, and then clinical endpoints as well as related to the target lesion failure aspects. So both covered, and then they followed the patients for a period of 1 year as well as 2 years. And what is interesting is that this registry, Pearl registry, showed the DCB Protege safe and then effective for ISR lesions as well as de novo lesions, and then a 2-year outcome also. The MACE outcomes are say comparable with other say results from the standard RCT data. So with this, I would like to show you some 1 or 2 cases here, because we have today a galaxy of cardiac cardiology of senior cardiologists here, and then they are going to share their opinion. And this is basically these 2 cases, non-STEMI presentation. Here you can see minimal disease of RCA. LCX, you can see the major I'm showing disease, and then LAD we can see basically mid-LAD bifurcation, something like dual LAD system. So non-left main bifurcation lesion, say when you deal 1-1-1, and then major trial shows that when you go with a 2-stent strategy, the results, follow-up results are not that great. So basically here what we have done is LAD is stented, and then the diagonal is actually DCB delivered with Protege. And the second case here, again, kind of non-STEMI presentation. You can see RCA normal or minimal disease. You can see medial 6 disease. Again, non-STEMI presentation, and then that is fixed. If you look at LAD, yeah, good sized diagonal. So medial LAD minimal disease. Basically, it is 001, but diagonal osteal disease. Again, say here covering diagonal with the stent is not really ideal, because then we have to compromise LAD. So in this branch vessel disease, osteal disease, with the minimal disease of LAD, again Protege is used successfully with the good follow-up result. You can see there only Protege is used. So with this, I would like to thank for the opportunity, and then I will join with you after exiting this presentation.
Dr. Ilyas, it was a good talk. If there are any questions in the panel, they can go ahead with it.
Sir, Ilya, one question to you. What kind morphology of lesion do we consider in de novo stenting, if imaging is available for us?
So in de novo disease, when there is long lesions, so we cannot do metallic jacket. Previously, we used to practice metallic jacketing of the entire RCA, entire LAD, something like so. Long lesions, and then the calcific lesions. Okay. Why calcific lesions? Because we do realize that in calcific lesions, even with a good kind of a calcium debulking strategy, say they are putting into 2 categories, and then if you really feel, then that can be covered with the stent, or otherwise, if there is no elastic recoiling, and then reasonable flow, and then in those situations where you expect you are going to get an underexpanded stent overall after stenting. So those calcific lesions, and then finally bifurcation lesions, where non-left main bifurcation lesion study clearly showed that overlapping areas, overlapping stented region, they never get endothelialized. There is no answer about how long a DAPT should be continued. And then the overlapped region always comes up with, restenosis. So that is the reason bifurcated lesion, again, they are trying to cover up with one stent and then a DCB for other vessels, and basically small caliber vessels. So when the reference vessel is less than 2.5, and in the 2.5 vessel, if you use any third generation stent, there also stent thickness is around 70 micrometer. And then finally, the net outcome in the long-term follow is not good. So in all those long lesions, calcified lesions, bifurcation lesions, and then small caliber vessel, DCB, de novo disease, DCB is attempted in all those references. If you look at on the clinical background, basic idea, those who are contraindicated for long-term DAPT, say for example, high bleed risk, CKD, so and then diabetes mellitus patients who are going to come back with recurrent lesions. So these are the certain clinical subsets that should be kept in mind. So these are the background of usage of DCB as of now. And obviously, we are talking about de novo. And then for ISR, I think our other presenters, they are going to share their experience.
Shall we
have
move on to
other
the next
presenters?
presentation?
Yes, better, sir, because stick to time.
I invite Dr. Karthik Sabhabati to deliver his talk.
Whoever is available, Sabhabati, I think he's online now.
Yeah, I'm online. If someone else can do it, I'll do it next. I'm just busy with the case.
Okay.
Okay, I believe
think
sir,
Babu sir
Dr.
has come.
Babu
Babu sir
Emily
has
is-
joined.
Good evening, Babu Emily, sir.
Yeah, good evening. Sorry, I had an emergency, so I just want to join now.
Okay, that's fine, sir.
Yeah.
You have a case to share, sir? You have anything to present?
I will be the next speaker. Maybe I'll share it next case. Yeah, maybe somebody else can.
Is there anyone else ready with the case? Venkatraman? Venkatrakrishnan?
So sir joined actually, but had to go. He got a call for some
Nitish?
emergency.
Nitish?
Sir is also not there.
Ilan
So we
Gomadan?
have Dr. Babu sir and Dr. Karthik Sabapati sir, who can present. Any of them can present.
Okay, I'll go ahead with the presentation, but I don't have a case, so I got stuck with something else. Is that okay?
Yeah.
That's okay.
So either we just discuss the things.
Okay. Can anyone share the slides, or should I do it?
I think
So
it's
as
better
you
you
said,
share it from your end,
yeah.
Karthik. Are you able to do that?
Yeah, I'll try.
Yes.
Just in the meanwhile, while Dr. Karthik is getting ready, Babu Edumali, sir, have you ever used DCBs in primary PCI? I think you should unmute yourself, sir. Please unmute yourself, sir.
Yeah. So primary PCA, I think so far I have not used. Maybe in non-STEMI conditions I have used, but primary PCA so far I have not got opportunity to use. Maybe it is all whatever we have done is all major vessel only. So maybe some branches, something somebody can do. So till date I didn't get an opportunity to use in primary PCA.
Dr. Narayan has some collection of cases
Yeah,
where he
I
has done
just
it in primary PCI.
Okay.
I think he can share his experience.
one of his cases I can show it right now, sir. If I can share my
I
screen.
think Karthik is ready with his presentation.
Yeah, then
Maybe
we'll go
after
to the
that,
presentation, sir. I think it's already getting late.
Dr. Karthik.
Yeah, sir. I'm there.
Yeah, thank you.
I'm also ready with my presentation. If we can do this.
Yes,
Sure.
sir. We can go ahead with your presentation.
Okay, then let me share my slides. Are my slides available? Are you able to see my slides?
Yes, sir. We are able to see.
Yes, sir.
So I'll be talking about recorded balloon beyond ISR. So indication and how the various indications have expanded. We all know that for a long time for ISR, definitely one of the options is to go for recorded balloon. Other options to do coated stent with another newer drug from the previous stent. So recorded balloon, we all know about this. So actually the purpose is to avoid the metal. So it's like metal-free angioplasty. One time we had absorbable stents where metal-free angioplasty was advised for that. But now metal-free angioplasty means mostly we are all thinking about recorded balloon. So initially it started with all balloon dilatation, balloon angioplasty, then stents came. Now again we are going back to the stentless era, where more and more usage of a recorded balloon has increased. That will reduce the need of duration of DAPT also. So patients who are going for surgery, most commonly we see, I'm working in MGM healthcare where there are so many surgical departments. So they say that patient has to go for surgery. So today also I had a patient, but patient who underwent spine surgery and then again had a collapse and then we had to do angio. So in those kind of duration, actually going for a stent, either the stent should be ultra thin, which will need this thing lower duration of that, or better to preferably go for a drug-coated balloon, which will need lesser duration of dual antiplatelet therapy. And more and more lesions are treated with less stents. And we know that stent failure, stent fracture, and so many other complications can happen with stent also. So that is avoided with this drug-coated balloon. And instant restenosis, definitely the late lumen loss at 6 months is very low with recorded balloon. And we can use for small vessels, very importantly, small vessel and diffuse lesions, more like from mid-LAD to HLAD, diffuse lesion, the OIM, PDA, PLB, many times we use there. And the bifurcation, so when you have done the main vessel stenting and bifurcation branch point, you can use. And patient with diabetes, who have small vessel disease extensively there, and patient with eye bleeding risk, as I said, they're going for a surgery or they have eye bleeding risk, those kind of patient, when you do, then go for a recorded balloon. And in ACS situation also you can use. And so these are all the expanded indications. So always small vessel, osteal is not mentioned here. That's a bifurcation. They mean that only. So osteal lesions, bifurcation, side branch lesions, and then diffuse lesions. So those are all very, very common indications where we use. And in addition to ISR, instant restenosis, and patient with eye bleeding risk also. These are all very common indications. We have so many trials for that. I have a few cases to present also, like starting from Restore trial, Basket trial. So many trials are given different things. But do you know small vessel disease less than 2.5 mm? Yes, you can go. The smallest drug-coated balloon available is 2 mm. So anything. So from there you can go. So below that, I think you cannot do a drug-coated balloon. And because sometimes small vessel you go and then do that also, there is a small dissection happens and you should be in a position to go for a stent also. So we have to see that. And large vessels also, people are using, more and more people are using that mid-LAD. They come to mid-LAD and mid-L6 and mid-RC, and people have started using. Even proximal LAD, some people have started using. But I think that still proximal LAD maybe is a place where we don't have major this thing, evidence, randomized control trial in the guidelines does not come. Or we have 6 months to 12 months, 2 years follow-up for all large coronary vessels also. People have started using that. Bifurcation and non-bifurcation lesions also, people have started using that. And And as I said, bifurcation lesion, yes. So there is a tendency whether you have to go for drug-coated balloon first in the side branch, then you put the stent in the main branch, because after that people don't want to go through take the drug-coated balloon through the struts of the main vessel stent. But I have seen practically people using even main vessel stent and dilate, then they go for drug-coated balloon, and then after that even kissing balloon dilatation they do. Earlier, we know that drug-coated balloon is a drug delivery balloon. It's not a dilatation balloon, so you have to pre-dilate and then prepare the bed, then take the drug-coated balloon. But after that, when you want to do a kissing balloon dilatation, will you do? People were hesitant to do, but now they say that no. Once you a perfect drug-coated balloon will deliver the drug into the endothelium once it in place. So once you dilate it at 6 atmosphere, 8 atmosphere. And after that, you can go ahead and then do, because studies have shown, imaging studies have shown that this drug is adherent to that, it's all embedded in the endothelium and then intimal layer. So once you dilate it, after that post dilation, you should not alter that. And a long diffuse lesion, that is one common thing. So as I said, small vessels, osteal lesion, bifurcation, ISR, long diffuse lesions, and patient with no eye bleeding risk. So those are the indications very commonly we should see. And long diffuse lesions where I commonly use in osteal lesions, long diffuse lesions, and even small vessels I use that. And patients with diabetes. So diabetic patients, we know that they come more and more and they're prone for restenosis. So many times have stents have studies comparing stents with CABG. So sometimes the restenosis rate or repeated revascular rate is more once you use stent compared to CABG. That's what our surgeons always say. Especially in TVD patients, all those things. So there, wherever you want to put stent, you do this, and where diffuse lesions are there, then you can go for diabetic patients. No, you can go for drug-coated balloon also. And patients with eye bleeding risk, as I said, patients implanting surgery, or immediately after surgery, you want to do the always drug-coated balloon is there. So to tide over the situation where the duration of DAPT is very less, maybe 1 month you can use, and after that you can go for a single single antiplatelet therapy also. In acute coronary syndrome, so studies are there, meta-analyses have shown that STEMI and non-STEMI, there's not much difference regarding the incidence of MACE or individual components. So non-STEMI, I think all of us would have used, but STEMI still, I see that there are people who have used even plain balloon also. They do that and then thrombolize and see the recanalizability, they leave it and then they bring back after some time and see, and if needed, they do. But I would say that so drug-coated balloons are coming in that. I think we have other speaker who is going to speak about that. There are studies, a couple of studies we have shown that that can be done. Drug-coated balloon has lower late lumen loss in acute coronary syndrome also. And then 3 cases shortly I will present. Videos are playing. So this patient has both proximal osteoproximal LAD and diffuse and distal LAD also is there. And proximal middle LAD I have already stented. So now what to do about this diffuse lesion? There's a diffuse distal LAD lesion, and so protege. So drug-coated balloon. So pre-dilated already done, and drug-coated balloon was used. And then after inflation, this is the final result. Vessel is grown. So vessel will grow more and more. Beyond that, there may be dissection may happen. So I've done that, and then it has increased and it will grow further. And here is one case with the osteal lesion. Especially on the osteal lesion, I have stented. So you can see that osteal in the loop. They have not put my assistants prepared. They didn't put in the loop. Sorry. You see osteal. I will maybe freeze it and show. Yeah, osteal OM. It's a medium-sized vessel. Osteal OM significant lesion is there, and then so the pre-loaded with an NC balloon, then a cutting balloon was used, and then after that drug-coated balloon stage, and so final result that is improved. And then the last case where again so LAD middle LAD lesion is there, and this L6 OM. So you can see here the lesion is there. I think the LPDA which is having lesions. So you can see LPD here, the lesion is there. So it's a kind of small vessel. So first case was a long diffuse lesion. This is the second was osteal, so small vessel. So the lady is sending down, but you can see still that lesion is here. This part, if you concentrate here, yeah. So this is that. This is a long LPDA. So here pre-dilated balloon, NC balloon. So you have to always do adequate lesion preparation, because drug-coated balloon is a drug delivery balloon, not a dilating balloon. When it's not a pre-dilating or post-dilating. So after that, the angiocyclitis improved. Then we used a protease recorded balloon, and this is the final result. You see, so it is all well improved. So this part has improved. So LPD. So this is a small vessel which I have done. And we have ISR indications. Even in ISR, I have done patient to bifurcation stenting was done, left main to LAD and L6. Patient came with stent thrombosis. So that patient both, so left main and LAD and L6, both stent thrombosis were there, and some amount of ISR also was there. So I've used dilated, and then we did imaging. Actually, the patient came with not stent thrombosis, restenosis. So patient came with restenosis, but it's all stents were all well expanded. Again, we have did IVs, and then finally I did a cutting balloon and recordable also. That patient for 2 years is doing fine. So even a left main lady after ISR, I have used that. So that we know, everybody knows that indication. So other expanding indication we have to use. So then more and more usage of a recorded balloon is increasing. The Antonio Colombo was a strong supporter of a recorded balloon. So all his live cases also he does that recorded balloon. He goes to even proximal lady everywhere. And some amount of dissection also he says he tries to agree, and unless it is a flow limiting lesion. So large de novo coronary lesions are new indication suitable for bifurcations and diffuse coronary disease. Even ACS you can apply that. High bleeding risk patient also we should you can apply. Last 2 years I've shown in DCB technology. One side we have sirolimus, other side we have paclitaxel stent, and then so paclitaxel recorded balloon. And then more and more companies are releasing with paclitaxel recorded balloon also. And it's still large ongoing follow-up data needed to validate the efficacy and safety of DCB compared to recorded stent, especially in the proximal lesions. Thank you.
Thank you, Babu Ermli, sir. I think we'll move on to the next presenter, Dr. Karthik Sabhabati. I think he's ready.
Yeah. So is my screen visible? Yeah. Yeah. So am I audible and visible?
Yeah.
So first of all, warm good evening to all my colleagues. So today I haven't brought any cases, was busy. Just now I have finished a case and I'm busy in my OPD. So I've asked my patients to wait, and I'm extremely sorry for that. So today we'll be talking about the basic steps of DCB angioplasty. Okay. So it's a valuable technique for especially in ISR and also certain de novo lesions. So here is a step by step. It is basically a revision of what everybody knows. So the first and foremost thing is the lesion preparation. So we need to prepare the lesion adequately. So many of them, like, they don't prepare the lesions, they don't predilate properly, or they don't crack the calcium. So it is one of the most common causes for the DCB failure. So when used properly, it produces good results as equal to a drug-eluting stent. So usually we can use both a semi-compliant or a non-compliant balloon with a 1:1 balloon to vessel diameter ratio. This is where everyone failed, because in a diseased vessel, we don't know what is the exact size of the vessel. So a diseased vessel, unless we do an IVUS, it may appear as 2.5, but in reality, it might be a 3.5 vessel. So if possible, we have to do an IVUS and ascertain what is the reference vessel, especially the distal reference vessel diameter, and do a predilation with 1:1. And we can also use cutting balloons or scoring balloons, or even rotational atherectomy, IVL, to modify the blocks and to achieve adequate predilatation. So when do you say the lesion is adequately prepared is, so we should aim for a residual stenosis of less than 30%. This is also where many people fail. They just do a two balloon predilation and they directly go with a DCB of 3 or 2.75. And the DCB, as Dr. Babu Elamale told, it is not a dilation. It doesn't cause any predilation. It's a semi-compliant balloon. So we have to adequately prepare it and make sure that we have a residual stenosis of less than 30%. And we have a TIMI grade 3 or even grade 2 flow, it's okay. And we have to exclude flow limiting dissections, especially type 3 dissections where there is flow limiting, we have to avoid and we have to go to a DES strategy, which I'll be saying. So, okay. So, so this is the strategy, as I told you. So 1:1. So the balloon to vessel ratio should be 1, or it should be a 1:1 dilatation. We can use whatever you want, like you can use rotablation, atherectomy, or lithotripsy. We usually do it with the SC and NC balloons, and we get a good predilation. So the same criteria which I've told already. And in some cases, we can even do an FFR to find out whether the lesion has been adequately prepared. So only when the FFR is more than 0.8, we should go for a DES strategy. And if the FFR is still less than 0.8, even after predilation, we should consider a DES strategy or doing a more aggressive predilation. And indications for stenting after this. So when we find there is a significant recoil, more than 30% residual stenosis, or flow limiting dissections, or the patients have ongoing ischemia like chest pain, ECG changes, hypotension. So in those conditions, a DES is preferred over a DCB. So this I told about the FFI. So DCB angioplasty, it is only for drug delivery and it is not for the lesion dilatation. Yeah, it was already told by multiple presenters. So DCB, it should be handled carefully. So we should always teach our fellow scrub nurses and the staff nurses to handle it properly and not to touch the DCB. Sometimes in a haste, they touch the DCB. They think that it is just like a normal balloon. And sometimes they may accidentally do an inflation and they may try to put a negative pressure on this. So all this, we should educate them not to do it. And positioning, it should be done as same as the scent. You should extend 2 to 3 millimeter and we should not have a geographic miss. And the DCB diameter should be a 1:1 ratio. So again, this inflation, there are multiple like timings, but a minimum of what I do is my practice is, so before going for that DCB, I usually use the NC balloon to dilate and keep it for 30 seconds and assess whether the patient can tolerate that much of a time of inflation. So if they are able to tolerate 30 seconds or more, definitely DCB they will be able to tolerate. If they are not able to tolerate, or if they develop significant hypotension or chest pain, that you can use a drug-eluting stent strategy in this. This is my personal opinion, but I'm not sure because many patients, they don't tolerate and we are forced to deflate the balloon earlier, causing drug loss, and it is not delivered appropriately. So no, adequately, so we have to maintain the pressure. Usually the nominal is around 6 and for almost all balloons. So we have to maintain it for at least 45 to 60 seconds. So manufacturers vary. Some say it is 30, some say it is 60. So at least 45 seconds is what I practice in my clinical experience. And expedited delivery, yeah, that is also important. Some take their sweet time to take the balloon and deliver it to the lesion site. Once the DCB is inside the guide, it starts eluting the drug. So as soon as possible, you should take the DCB and you have to deposit in the lesion site. So a prolonged exposure can cause insufficient contact time or drug loss, and that can cause the treatment failure. And one more thing is you should always avoid post dilation after a DCP. Always you should avoid an IVUS, and you should always avoid multiple angiograms after the DCP. So usually we take a single final shot, and there is always a dilemma whether we should give a nitroglycerin or a nicorandil after the DCB, and whether we should check for adequate expansion. That again is it's debated, but we should always keep in mind that we should minimize the uh, any interaction after the DCB has been used. So I usually take a single shot with the wire and come out. In case there is a dissection, I may go in with the wire. I don't remove the wire till the last shot, and I usually don't give this NDG and Nicorandil unless the patient has a slow flow. And post DCB result assessment. So this is what I told you. You should check for dissections, recoil. Dissections are very, very common, especially in the distal circulation. Many of us use it for the distal LAD. So where dissections are very, very common. So if the dissections are not flow limiting, actually it is helpful, and it helps in the position of drug in the vessel, and it prevents like further restenosis. So type A and B dissections are acceptable. Only type C dissections or spiral dissections or flow limiting dissections. So that should be managed with a DES strategy, with a payload. So that is what they have said. And the bifurcation lesions, yeah, this is what very, very common, and it has become a great savior for us, especially when we stent the LAD diagonal and LCX OM. And the distal RC, APDA or PLB, where we stent and the other branch has become pinched. So what we try to do is we always recross through the stent, and we do a pre-dilation and come out. But after the DCB strategy, we have another weapon with us, so where we can go and access the side branch and definitely do a DCB and come, and it has produced good results. So I myself have tried even for left main lesions. So this LCX ostium is a particular area where we are always worried about. So and left main to LAD stenting with an DCB to LCX ostium have been used for almost 4 or 5 cases, and many of the operators are very happy with this. And we can where you can avoid a complex bifurcation stenting strategy in the left main. It saves a lot of time and a lot of metal in the left main. And in CTO, a hybrid strategy, like the main lesion where we do a drug-eluting stent, and the distal to the CTO, we can do a POBA or a drug DCB strategy can be pursued. So this is a flow chart. The same repetition of whatever I told you. This is for a bifurcation lesion. So the main vessel and the side branch, if both are there is no flow limiting dissection and the residual stenosis is less than 30%, you can go for a DCB or both DCB on main vessel and side branch. Or if the residual stenosis is there, and if you think that main vessel is a very large vessel and there's a lot of calcium and you think there is a recoil, you can go for a DES in the main vessel and provisional stenting on side branch, or a DCP to a side branch. And if both the results are not acceptable, we are forced to do for a DES on the main branch and a provisional stenting bifurcation, or we can go for an upfront bifurcation strategy after the pre-dilatation. And for CDO lesions, same. If there is what do you say, lesion preparation has been done using intimal wiring, subintimal approach, it is always preferred to use a drug-eluting stent, because there is a high chance of restenosis and occlusion of the vessel. So always drug-eluting stents for subintimal approach. And if it is a simple CTO, like you have crossed it with without causing any dissection, you can use either DCB alone or DCP to the lesion site, and distal site, if it is okay, you can leave it as such, or use a DCP to the distal to the stenting, or distal to the CTO site. And again, Dr. Narendran has asked about the treatment approach for acute MI. So I have used for maybe 2 or 3 cases, but not for the lesion site, but distal to the lesion. Yes, it was, if I remember correct, it was a middle AD total occlusion, thrombotic occlusion. So after I opened the middle AD, I found the distal LAD diffusely diseased, and it was also flow limiting. There was another 90% lesion in the distal LAD. So for that, I had to use DEB. So I don't think whether you can consider this as an acute MI. And for another case, what happened was the ramus was totally occluded, and the LCX or the early OM was totally occluded, and the LCX early OM was a bit hazy, and it was a tight stenosis. So I had to put a stent from the ostial ramus, and I had to do a DCB to the LCX. So this was my experience. And many cases for diagonal, we have done DCB after stenting the LADs. So only DCB without DES stent, I haven't done in my practice. I use it along with the DES to distal lesions or to the side branch lesions in acute MI. So this is also the same lesion for normal. And IVUS. So as I told you, we don't use IVUS after DCB. We can use it as much as we want before DCB, especially when the whole vessel is diseased. We are not sure what is the vessel size. I always use an IVUS because many times what we think as a 2.5 vessel becomes a 3.5 vessel after IVUS because the whole vessel is diffusely diseased. And DAPT, and there was another case where a middle lady had a 80 to 90% lesion, and the patient had a cancer and he was posted for surgery. So what we did was we did a DCB to middle lady, and after 1 month we had stopped DAPT, and he underwent surgery without any issues. So, but the recommended use is for any acute MI, you have to do it, continue dual antiplatelets for 12 months. And if it was an elective case, there are many studies you can even stop after 1 month. So I even have a personal experience of stopping antiplatelets, both antiplatelets after a middle lady DCB. Thank you.
Thank you, Dr. Karthik. That was an exhaustive and very informative presentation. I think we'll move on to the next speaker. I think Dr. Ilangomaran has joined us. Dr. Ilangomaran?
That's a great presentation from Dr. Karthik, but one observation. So basically, the period of contact is 1 minute lesser, but lipophilic substance, and then they make the maximum tissue penetration at that time period itself. So there is no comment on further injections, all those things. Imagine coronary vascular system is a dynamic structure. Even after DCB, blood is flowing constantly. Never forget that. So there is no issue about post ballooning, post DCB, giving reasonable contrast checking, and then drug delivery, all those things. That 60 minutes contact time, lipophilic, good tissue penetration, and that works well for a period of 6 hours to maximum of 14 days. That is the concept. There is no word about the delivering other drugs or injections afterwards.
Okay, sir.
If Dr. Ilangomaran is not ready, I think.
Sir, he is there, sir. Dr. Ellen is
Yes,
there
sir.
now.
Yes, sir. Good evening, sir.
Good
I'm
evening.
Dr. Lin.
Yeah, I
Sorry.
think you can go ahead, Dr. Ilangomaran.
Yes, sir. Yes, sir. Sir, I have login with myself, sir. They have to share my screen.
Sir, if you allow, shall I share the presentation?
Yes, yes, madam.
Okay, okay, sir.
Good evening, sir. Dr. Sriram, sir, Ilaraja, sir, Babu, sir, are all my seniors, my mentors. Thank you for giving me this opportunity, sir. Drug-coated balloon, a hybrid approach for treating diffuse coronary artery disease, sir. Personally, I am using around 15 DCBs per month in Tanjavur, sir, Kamachi Hospital. So far, for the past 1.5 years, I am following up the cases. They are all doing really fine, sir. Non-flow limiting dissection, as Karthik sir told, non-flow limiting dissections with a good vessel area. The patients are doing really fine, sir, and I am giving only 1 month of antiplatelet therapy, and they are doing really fine, sir, for branch vessel disease, small vessel disease, and all. For acute MI also, in extensive triple vessel diseases, severely calcified vessel, we are referring them for CABG. They are presenting as ACS like total RCA cut or total LAD cut. Other diseases, other vessels are massively diseased. Before I used to do POBA, and I will give the case to CABG, sir. Now I am, although there is no, I am not sure whether the DCBs can be used on thrombotic lesion. But in acute LAD occlusion, acute RCA occlusion, I used to open the vessel with a normal plain balloon dilatation, followed by I will
I will approximate 1:1 DCB balloon over the occlusion site, sir. For the after 3 to 4 weeks, they will undergo CABG. So after the during that mean period, there was no even free. Patient was even free. They don't have any chest pain. Their ECG comes to baseline normal, and they are doing CABG, and they are doing for around 7 to 8 cases are like that, sir, and they are all doing really well. In extensive triple vessel disease, also in acute occlusion, instead of doing plain balloon angioplasty, I am using DCBs to open the vessels, and they are all doing really fine, sir. Introduction: the challenges of diffuse contact disease. Usually, we used to do drug-eluting stenting is the most used reversal strategy in current clinical practice. But there are some drawbacks in drug-eluting stents, even with recent generation drugs. There is a late and very late instant thrombosis, even with the newer generation drug-eluting stents, sir. Notably, in case of diffuse contractile disease, which affects 20% of patients undergoing PCI, leads to long and overlapping stent, which has been consistently identified to substantially increase the risk of instant restenosis, late stent thrombosis, and terminal vessel injury. There was a shift between drug-eluting stent to drug-coated balloon. The main advantage is there is no permanent implantation. We are reducing the metal load. So there was reduced risk of instant thrombosis, very late stent thrombosis, ISRs. This also gives us a future opportunity to give CABG, or later we can do stenting. It also promotes posture remodeling, because vessels vasomotor function will be preserved when we are not putting the metal over the vessel. The endothelium and the vasomotor function will be preserved, so it can go for posture remodeling when we use drug-coated balloon alone instead of putting the stents there. Next slide, Meena. The current latest evidence and approved indications are for ISR, for de novo small vessel lesions, de novo large vessel lesions, bifurcation lesions, and other things. High bleeding risk patients who are not candidate for dual antiplatelet therapy for long duration of time, we can use drug-coated balloons. And those who are with diabetes, who are having diffuse disease, we can use those. You can use drug-coated balloons in those patients also. Next slide, please. Why combine DCBs and drug-eluting stents? Benefits of hybrid approach. To reduce the stent length, we can approximately reduce the stent length. Each 5 millimeter increase in stent length increases the target lesion failure by 7%. And overlapping stent, when we use overlapping stent, there are more 46% more chance of target lesion failure when comparing with non-overlapping stents. To reduce small regulating stent implantation, when we use stent of less than 2.5 millimeter, it increases 26% target lesion failures. Current PCI approaches for proximal segments and main branch bifurcation, regulating stents are widely used. Drug-coated balloons are used in distal segments and side branch bifurcations. To preserve the DCBs are useful in preserving the future treatment. For example, DCB treatment regimens remain accessible for future stent or CABG to mitigate side branch compromise, because it reduces the cardiac shift. So side branch compromise is reduced, and it also reduces the duration of DAPT. So for high bleeding risk patients, we can safely use these drug-coated balloons instead of drug-eluting stents. Next, madam. There are some mechanical advantages, as we know, as I told you earlier, vasomotor function will be preserved. DCB's preservation of endothelial vasomotor function, restoration of vascular physiology, and promotion of positive vessel remodeling. There is DCB has been associated with a higher incidence of late lumen enlargement, observed in up to 60% of cases. This phenomenon is particularly notable with the PCBs, paclitaxel coated balloon, whose antibiotic effect is mediated by inhibition of microbial polymerization and activation of pro-apoptotic signaling pathways in vascular smooth muscle cells. Clinical advantages: we can use in very young or elderly patients. A DCB-only approach may be preferred to minimize the long-term related complication, reduce dual DAPT duration respectively. An important advantage of DCB angioplasty is the preservation of future treatment option in non-stent vessel, because we can preserve the patient when we are not putting the stent in the distal segment vessels. Instead of putting the stent, we can use DCB. Means they can undergo grafting in the future. Next question. Next slide, please. Procedural advantages. While regulating stents are typically reserved for segments more prone to recoil or requiring mechanical scaffolding, DCBs may be optimally used in adjustment or downstream segments with the diffuse disease and small reference vessel diameters. This strategy mitigates several intrinsic limitations of regulating stent only PCI. By reducing total stent length and avoiding unnecessary stent overlap, the overall metallic burden is minimized. Furthermore, it helps preserve side branch patency, which is of prognostic relevance when supplying a significant myocardial territory and avoids stent implantation in small vessels. It involves adequate lesion perforation, either by physiological assessment followed by adequate lesion perforation. DCB inflation, usually it is for 60 seconds. Then physiological reassessment. If FFR is less than 0.75, the result may not be acceptable. If it is more than 0.75, successful result. Next slide, ma'am. Optimal DCB outcomes depends heavily on meticulous lesion perforation. As we all know, adequate pre-dilatation is essential to create sufficient vessel diameter and ensure proper drug transfer. Calcified or fibrotic plaque requires aggressive modification like atherectomies, rotational or calcium debulking techniques, cutting balloons or coaling balloons to create microchannels for enhanced drug uptake. That is like cut and coat technique. Advanced imaging modalities like IVUS OCT can be used. FFR should be used in main vessel drug-coated balloon usages because if the FFR is less than 0.75, we may need to stent the vessel if the result is not if the restenosis is if the vessel diameter is not less than 30%. Next slide, ma'am. As we told earlier, the acceptable result means non-flow limiting dissections or residual stenosis is less than 30% or FFR more than 0.75. That means our DCB result is successfully accepted. For inadequate results like there was flow limiting dissections or residual stenosis more than 30%, and if the FFR is less than 0.75, we may put a drug-eluting stent like vascular scaffold to prevent late lumen recoiling, to prevent a future target vessel failure. Next question. There are some trials which compares recent hybrid usage of DCB with the drug-eluting stent PCI for diffuse and long CADs. All these trials successfully, for especially paclitaxel coated balloons, major adverse cardiac events were numerically reduced, and target vessel revascularization and the target lesion failure is also comparable with drug-eluting stents when using paclitaxel coated DCBs. Next slide, bro. In the conclusion, hello.
So we can hear you.
Yeah, we can hear you, Milankumar.
Sorry, sir. The blended DCB drug-eluting stent PCI represents a feasible and promoting revascularization strategy for patients with diffuse or long CAD and bifurcation lesions. Large observational studies have demonstrated its potential to reduce adverse events comparable to traditional drug-eluting stents only PCI. This approach should be seen as a step forward tailoring PCI strategies to individual patient and lesion characteristics. Future RCTs are warranted to validate these encouraging findings, define the optimal implantation technique, and clarify the roles of intracoronary imaging and physiological assessment in guiding blended DCB or drug-eluting stent PCIs. Thank you, sir.
Thank you, Dr. Ilankumaran. Shall we wind up the presentation, Garima?
Yes, sir. If anybody has questions, you can just take it. Otherwise, we can just wind it up, sir.
I'll just wind it up with some points from my side. So classically, all these DEBs were used usually for the classical indications were ISR. The first ISR, or after putting two metals in the vessel, then you get an ISR. Then osteal L6 was on isolated osteal L6 lesion was on classical indication. Then high bleeding risk or any patients awaiting for an immediate surgery where you cannot give a prolonged DAPT. All these were the classical indications for DEB initially. Then it expanded to diffuse long lesions where you can use an hybrid strategy in the same vessel where you can stent the proximal vessel and do a depth to the main vessel to reduce the metal load, as Ilangumaran explained. So in case of diffuse long lesions, and in case of de novo small vessels less than 2.75, 2.5 mm vessels where you don't want to stent, don't want to give a metal, then again you can use a depth. Or now it has expanded even to long, large vessel de novo lesions also, provided we have adequate imaging backup and pre-dilatation. And in cases of triple vessel disease, as Ilangumaran noted, sometimes we use when we face up with an primary PCI where we stent the culprit lesion and there is a bystander lesion, there is a one more tighter stenosis on the other vessels. We go for an hybrid strategy where again in the culprit we use the DES, and in the non-culprit lesions we try to use the DEB and commot to reduce the metal load. And recently off late, very young MIs are there where we see MI patients, between the age of 20 to 30 also. So more commonly they might have some plaque erosions or some minor plaque ruptures which might lead to the vessel occlusion. So once the thrombus is all aspirated, the TIMI flow is good, and if the lesion and the underlying lesion is not very critical, and if you have an imaging backup and if you prove it as a plaque erosion, then probably DEB is also a very good option to restore the flow and come out with without a metal, in especially in young patients. And recently, as me and Naren are seeing so many patients with young MI, where you just open up the vessel after a pre-dilatation or just a balloon daughtering or thrombus aspiration, and you see a lot of huge myocardial bridging in the LAD, especially in the mid LAD. Once you open up the vessel, there's a significant myocardial bridging where we feel, and there is no residual significant lesion. So in those cases of primary PCI, DEB for those cases bridging, especially in the middle AD. And lesion preparation, yes, definitely based on the, if you have an imaging, then lesion preparation according to the lesion morphology is always the best way. You can use either of the balloon score, the semi-compliant, non-compliant, scoring, cutting, or rotablation. That all depends on the plaque. The plaque has to be modified well. And if you have imaging, then definitely yes, the MLA cutoffs will guide you to have a better results for a DEB. And intimal dissections are definitely needed. If there are medial dissections which need not, some great stalwarts who use DEB, they say medial dissections are good until otherwise they don't compromise the vessel flow. And residual stenosis and FFR criteria are always there to to establish the endpoints of your success of DCB, and imaging endpoints as well. The MLA cutoff values, if they're good, you can do a DEB and come out. And I like the particular point of Karthik Sabhabati where he used to, where he said he inflates an NC balloon for 30 to 40 seconds and holds it and sees whether we checks whether the patient is able to tolerate the ischemia. That is a good point, and it can also assess the recoil also. And regarding post dilatation, NTG contrast usage, I don't have post dilatation. Maybe I try to avoid, unless otherwise if there is a compelling indication to post dilate after a DEB. Contrast and NTG, usually I don't hold myself just for the purpose, but some DCBs by OCT studies have proven that there are large particles that stick onto the endothelium. So that might get that is being seen in the OCT run after the DEB has been used. So there are things, sometimes those kind of DEBs with large particles can cause a transient slow flow kind of phenomenon after the DEB. So sometimes the DEB can little get washed away with all your cocktails and the contrast, but that is only in some DCBs. And sirolimus paclitaxel DCBs, I have a set of people with an angiographic follow-up. The late lumen gain is definitely not that great angiographically, but late lumen loss is definitely not there. And sizing of DCB sometimes is very complex. When you have a long lesion, when you have a main vessel, once the daughter branch is given and you size the DCB according to the distal main vessel, whether the drug gets coated in the proximal main vessel after the huge side branch is always a question, whether the drug is eluted properly. So I am not a big fan of using the same DEB multiple times in the same vessel, just for this reason. Maybe because after it branches and gives a daughter vessel the adequate, I don't think so the adequately the drug is pushed into the proximal main vessel. Yes, there are cases where I have used kissing debs also, two debs in the proximal and the side main branch. And personally, through angiographic follow-up of a considerable number of patients, I have seen long lesions, especially in diabetics. There's not, I mean, not much of a good lumen gain. There's some amount of late lumen loss also with debs. But non-diabetics, young people with short segment lesions with the deb, definitely their angiographic follow-up is good with no late lumen loss. I think that's it from my side.
Yeah, thank you so much, sir. And on behalf of Translumina and attendees also, sir, who are watching us, I would like to extend my heartfelt gratitude to all of you for taking your time out, invaluable time and expertise today. So thank you to all our faculties and have a great evening ahead, sir. Sir, Dr. E. Babu, sir, anything you would like to add, sir?
Yeah. So I think Dr. Sriram has wonderfully summarized. So sorry, I couldn't contribute much because I was busy with other case. I was talking to our phone also with my emergency patient. But DCB usage is increasing. People have to, I think, still some awareness has to come among our cardiologists also. So there are some people who are hesitant to use that. I know that one cardiologist was CTO expert who does a lot of angioplasty, but he is still against DCB. But I think we should create awareness among our cardiologists and other physicians so that they will know that, and then patient will automatically accept that. As we have discussed, indication has increased. More and more usage of DCB will reduce the mental load, and then response rate will come down because of that. Thank you.
Thank you, sir. Thank you.
Dr. Narendran, sir, anything from your end?
No, ma'am. I think Sriram has summarized it really well. So I think all the points has been covered.
Thank you so much to all of you for your invaluable time. We shall be seeing soon, maybe in another session of ours. So thank you and have a great evening ahead.
Thank you.
Thank you.
Thank you.
Thank you.
Good night, all of you.